Good morning, everyone. Thank you so much for joining our Fall 2021 Implementation Science Seminar Series. We are now starting the series in a webinar format, which is different from what we've done before. But there was a need for some heightened security, so we will see how this works. Although we can't see each and every one of you as we have been able to do before, we really appreciate you being here. And we welcome your comments and questions in the chat at any time, which I will be moderating. And at the end of the presentation, we will have a Q&A session to address your questions and comments. I'm really happy to have you here for this Fall 2021 Implementation Science Seminar Series. These series have been going on for the past 3 years out of the Department of Psychiatry and Human Behavior in our Implementation Science Core. And we have now partnered with the Advance-CTR, as well as the Brown School of Public Health ARCH project. So we have this 3-way implementation science seminar series, beginning with this fall series. And really grateful for the Advance-CTR staff and infrastructure for supporting our program. I'm really excited today to introduce you to our guest speaker, Dr. Jennifer Sullivan, who is an Associate Professor of Health Services Policy and Practice at the Brown School of Public Health, as well as the Associate Director of the Long-Term Services and Supports Center of Innovation at the Providence VA, which is a health services research and development center. Dr. Sullivan joined Brown School of Public Health on September 1st in the Department of Health Services Policy and Practice, and we're so happy to introduce her to the wider community of Brown and affiliated investigators who are really committed to implementation science. So Dr. Sullivan is going to be a great addition to these efforts that we have here at Brown. Dr. Sullivan has been using mixed methods designs and implementation science throughout her career to assess implementation and clinical outcomes of institutional and non-institutional long-term services and supports in the VA. She has led a number of projects. She's been recently funded as a co-PI, excuse me, to assess hospital and home implementation in the VA and the spread of the model to 10 additional sites. She's been working in the area of suicide prevention for older adults, especially for people with Alzheimer's disease and related dementias. Excuse me. As of October 1st, Dr. Sullivan became the Associate Director of Long-Term Services and Support Coin at the Providence VA. I have had the incredible fortune of working with Dr. Sullivan over the last, 18, 19 years. So I'm really, really excited to now have her in our Brown community and in Providence. So thank you so much, Dr. Sullivan, for being here today. I'm sorry that I'm having a choking attack and really cannot wait to hear what you have to say about sustained implementation and identification of implementation strategies. Thank you so much for being here.
Thank you, Ronnie, and thanks to Advance-CTR for the opportunity to share this work with you today. I will be presenting on implementation strategies and sharing an example from a project where we mapped barriers hindering implementation to implementation strategies within a VA program called the Staff Training in Assisted Living Residence Program, or STAR-VA, and that was implemented within the nursing home setting. And as Ronnie mentioned, that I can't really see you or the chat box while I'm in presentation mode. So we'll hold questions to the end of the presentation when there will be time devoted to answering those questions and having some discussion. And Ronnie will be monitoring the chat box for me in case there are any burning questions along the way. So in terms of the content I plan to cover today, we'll first focus on a quick refresher on implementation research methods, then discuss what implementation strategies actually are. Then we'll focus on ways to select implementation strategies and report and classify them. Then next, we'll pivot a small bit to discuss the importance of identifying determinants of implementation success and focus specifically on ways to identify implementation strategies using the CFIR-ERIC matching tool. And then finally, as I mentioned, I'll provide an example of how we map barriers to strategies in the STAR-VA project, as well as share how those results informed additional sustainability efforts. So to get started, I wanted to show where in the implementation research methods pipeline implementation strategies fall. Many of you are likely familiar with Proctor and colleagues model, which defines implementation science, but also implementation outcomes. On the left-hand side is what is being implemented, or the evidence-based practice. And on the far right-hand side are the clinical outcomes being targeted by the intervention. What you don't always see explained in the literature are the boxes falling in the middle of the diagram. How do we put the thing, or the evidence-based innovation, into practice? So those how-to components are implementation strategies, which then also are related to implementation outcomes and service outcomes that ultimately lead to changes in those clinical outcomes. So the focus of this talk is really about implementation strategies, which are specifically part of the how component in this logic model, or that second box. So what are implementation strategies? They have been defined in slightly different ways in the literature. I think one of my favorites is Jeff Curran's explanation that they are the stuff we do to try to help people and places do the thing, or the evidence-based intervention. Proctor et al. Said they constitute the how-to component of changing healthcare practice, specific means or methods for adopting and sustaining interventions. So implementation will be successful when implementation strategies are tailored and they're responsive to local context. And current research suggests implementation strategies should be tailored over time, and then should consider 3 levels of context. So behavior change at the individual level, team and organizational level change, and then structural or policy levels as well. So about a decade ago, maybe a little less, because of the lack of clarity about implementation strategies in the literature, the expert recommendations for implementing change, or ERIC study, gathered survey responses from implementation experts about implementation strategies to help standardize this definition, or the definitions. And there was an expert panel using a Delphi technique to generate consensus among the experts. This resulted in a compilation of 73 strategies. And I've taken a screenshot of the article title and authors, as well as a screenshot of additional file 6, so you can see it and look at it in your spare time. And this additional file 6 provides the most comprehensive list of the strategies and definitions of them. So it's kind of a go-to resource if you're looking to learn about strategies. Now, following this work, an additional study then used concept mapping to group these 73 strategies into 9 categorizations, as you can see here in this image. So concept mapping involves generating, structuring, and analyzing ideas to create a visual map of concepts that are rated on specific dimensions. So for example, importance or feasibility. And there were 9 resulting clusters: developing stakeholder interrelationships, using evaluative and iterative strategies, training and educating stakeholders, changing infrastructure, engaging consumers, adapting and tailoring to the context, utilizing financial strategies, and providing interactive assistance. So one of the first steps we need to do is select implementation strategies. And there are multiple considerations here, including the context of the organization in which you're implementing, use of theory to help select strategies, like the various dissemination and implementation models, frameworks, theories, or approaches. I wanted to quickly highlight the health equity implementation framework, which is on the bottom right here on the slide, which suggests adapting certain components of the implementation effort increases the likelihood of improving health equity. So for example, tailoring implementation strategies, or really the innovation itself as well, can enhance uptake of the innovation. So in addition, other things to consider when selecting your implementation strategies are the opinions of stakeholders, utilizing the intervention about which strategies they would actually like to use, and then considerations about selection based on the current state of empirical evidence. Additionally, we need to consider which methods to use to help you select strategies. So one method would be formative evaluation, which Stetler defines as a rigorous assessment process designed to identify potential and actual influences on the progress and effectiveness of implementation efforts. And this occurs at every stage of the evaluation. The method provides you with an understanding of factors affecting implementation, such as barriers and facilitators. Another more recently developed method would be to use implementation mapping to guide selection of strategies. And Byron Powell describes it as, or defines it as, a systematic multi-step method for developing interventions or implementation strategies that is inherently ecological and incorporates theory, evidence, and stakeholder perspective, which I had shown, on a previous slide. So there are really 5 tasks, as you can see on this slide, to conducting implementation mapping, including a needs assessment, identifying adoption and implementation outcomes, performance objectives and determinants, choosing theoretical methods, selecting and creating your implementation strategies, producing implementation protocols and materials, and then evaluating your implementation outcomes. So these are all important considerations in implementation mapping. There are also several other methods for selecting implementation strategies. I've included a screenshot of Byron Powell and colleagues' article, or at least the title, laying them out. In addition to concept mapping, which I already introduced very briefly, and you can see an image of here now, there is group model building, which is a system dynamics-based method involving engaging stakeholders and collaboratively developing causal loop diagrams that model these complex problems to identify opportunities and then strategies for improvement. Another method is conjoint analysis, which is a quantitative method requiring participants to select different profiles, which allows for determination of how stakeholders value different attributes of implementation strategies or even facets of interventions. And then another is configurational comparative methods, or CCMs, which uncover causal dependencies and identify combinations of strategies that can make a difference on outcomes. So there's been a lot of work in this area and methodology for selecting implementation strategies in recent years. So once you've selected your implementation strategy, it's important to then report what they are. So this includes naming and defining your strategy, and then also specifying your strategy using the 7 domains you see on the slide. So that includes the actor or individuals enacting the strategy, the action, what are the steps or processes used, your action target, what level and determinants are you targeting, temporality, when will you employ that strategy, your dose, how much of the strategy will be used. For example, how often will a facilitator check in with a site or for how long? Implementation outcomes affected. Will the strategy focus or target feasibility, fidelity, or cost? And then finally, justification, where you provide a rationale for why you are using this particular strategy. So there's also been some additional work thinking about how we should classify implementation strategies. Dr. Lehman and colleagues proposed a classification system which adds greater conceptual clarity to these definitions. So for example, how are strategies delivered, supported, and translated at multiple stages of the work? And these distinctions help improve communication within the team doing the implementation, and also help better identify the need for or use of the implementation strategies. So there were really 5 classifications, including dissemination strategies, which target staff and stakeholder knowledge, awareness, and attitudes and intentions to adopt the intervention, implementation process strategies, which remind me of implementation mapping, really, where you're enabling an innovation to be planned and delivered over different stages. You assess context, engage with your stakeholders, and monitor implementation process and make improvements along the way. Integration strategies, which are aimed at integrating a specific innovation into a setting. So for example, if you wanted to introduce staff to a new practice, you likely need to revise their roles and responsibilities responsibilities. And then you might need to create a new record system in which to do so. And then capacity building strategies increase motivation and capability of people to engage in implementation. So something like delivery of training. And then finally, scale-up strategies aim to build capacity to implement policy, practice, or services in multiple settings. So this could include something like train the trainer initiatives, and then maybe developing some system infrastructure to collect data. So understanding what happens when an evidence-based practice is implemented is important to address implementation challenges, as I think I've stressed multiple times so far in this presentation. And the parable about a group of individuals who are blindfolded and touch an elephant to learn what it feels like comes to mind. So each one feels a different part of the elephant and comes up with an explanation of what they're feeling. So for example, the one who feels the tusk claims the elephant is a snake, while the other one who feels the leg thinks it's a tree. And the lesson is that we often fail to see the whole elephant or picture, really, for various reasons. So we have to really acknowledge that context matters. Systems are complex and multifaceted, but also that various perspectives of individuals themselves impact implementation efforts. So context can lead to variation in outcomes. So considering the influence of context is really necessary to explain how or why certain implementation outcomes are achieved or not. And before you can determine which implementation strategies to utilize, it's critical to consider determinants of implementation success. So determinants are factors believed or empirically shown to influence implementation outcomes, and many terms are used for determinants, including barriers, hindrances, obstacles, impediments, but also some positive enablers and facilitators as well. And context is highly represented in many theories, frameworks, models, and approaches. So one such framework is the Consolidated Framework for Implementation Research, or the CFIR, which allows a menu of constructs that have been associated with effective implementation. There are 5 domains: inner setting, outer setting, characteristics of the individual, intervention characteristics, and the implementation process. And I like this visual from the Center for Implementation. Within the 5 domains, you can see the sub-bullets of the 39 constructs. And the website is listed on the slide as well if you want to review in more depth and really look at those constructs and definitions in particular. So one recently developed tool for selecting implementation strategies is called the CFIR-ERIC matching tool. And the tool was developed based on survey responses from implementation experts, 169 of them, who chose up to 7 implementation strategies they believed would best address each CFIR barrier. Respondents had considerable variation in their opinions, and so wide heterogeneity of the endorsements obtained suggests there was relatively few consistent relationships between CFIR-based barriers and those ERIC implementation strategies. So more research is obviously needed to sort of better guide strategy choice. But although consensus was not strong, the tool provides a prioritized list of strategies to consider based on your knowledge of potential CFIR-based barriers in your own project, which we have found very useful. So I downloaded a version recently and saw that the name seemed to be updated to CFIR-ERIC Barrier Buster Tools, version 0.53, which I liked. The tool has 4 tabs. The first is a summary of how to use it, which I have here. The second lists strategies, which I didn't present because there's 73 of them. The third, which I also have on the right-hand side on the slide, allows you to select a 1 if that CFIR construct was a barrier in your project. This is where you would click the query button and then the magic happens, and then a final tab populates with your results, which I'll show you an example of in a few moments. So as I mentioned, there are several approaches to identify contextual determinants and strategies to address them. The work I'm using as an example conducted a formative evaluation to understand what the facilitators and barriers of sustained implementation were, and then map them to ERIC strategies using the CFIR-ERIC matching tool. So the project I wanted to highlight is STAR-VA program. It's a team-based, evidence-based intervention for managing challenging behavior symptoms of dementia in veterans in the nursing home setting, which in the VA is called the Community Living Center, or Community Living Centers. And this program includes several pieces. There's a partnership between a nurse and a mental health provider known as a nurse champion and a behavioral coordinator for their 4 core components: promoting realistic expectations of dementia, using effective communication, identifying and changing activators and consequences of challenging behaviors, and then increasing personally relevant, pleasant events. And there's an intensive 3-day training and 6 months of skills-based consultation, which involves competency evaluations of those local STAR-VA teams. And then CLC teams complete 4 to 6 cases during that consultation period. So CLCs were selected based on a competitive selection process. And there have been about 95 out of 135 CLCs that have participated in training and implementation of STAR-VA, with a number receiving retraining over the years from 2014 to 2018, which has led to efforts focusing on sustainment at this point. And then I wanted to have a quick aside about sustainability, which Dr. Elwee presented very well last week in her seminar. When we embarked on this work in 2016, sustainability research had really begun, but was in its infancy. So in 2018, this review by Rachel Shelton, you can see on the slide, highlighted important categories of factors that influence sustainability across various settings, which are dynamically related, hence the number of arrows you see. And these were outer contextual factors, inner contextual factors or organizational factors, processes, intervention characteristics, and the characteristics of those sustaining the programs. So these factors seem quite similar to what is in the CFIR, which I just presented. However, given the timing of the work and the lack of more recently developed guiding models and tools, we instead relied on a different framework, which at the time was targeting sustainability. So there are many theories, models, frameworks, and approaches you might use to guide implementation and evaluation efforts. And for this project, the organizational memory framework was used because it specifically focused on sustainability. And the framework sees sustainable change as a continued integration of an intervention into the usual ways we do business. So we hope to see sustained programs have made interventions a permanent part of the organization. And I'll read this quote that you can see here on the slide. Organizational memory refers to the storage of embodiment of knowledge in various knowledge reservoirs within the organization. The ability of an organization to sustain new initiatives, to institutionalize the initiatives in the organization's standard operating procedures, and to routine the initiatives to make them a permanent component of the organization. So there are 7 knowledge reservoirs, including people or the individuals participating in STAR-VA, relationships, the interactions between those individuals, organizational information space and tools, which are mechanisms allowing people to share information with each other, and structure of performance, which are expectations or anticipated behaviors and responsibilities for those participating. The final 3 knowledge reservoirs were routines and procedures, or the ways STAR-VA is built into usual practice, and artifacts and policies, which are tangible evidence of STAR-VA being integrated. So this could be through documentation or training, use of materials or IT solutions. And then finally, culture, the values, beliefs, and norms of an organization. So our team, led by Dr. Kim Carrito, obtained funding from VA Query for a larger evaluation of the program. The objective of this part of the work, though, was to understand more about the variations in sustained implementation across STAR-VA trained CLCs using the knowledge reservoir domains. And we interviewed a purposeful sample of 20 trained CLCs, and sites were selected based on 2 criteria. performance on an MDS or minimum data set, distress behaviors measure developed as part of the evaluation, and data regarding STAR-VA adherence to the approach collected through a survey administered by the Office of Mental Health and Suicide Prevention, our partner in this work. So we interviewed up to 3 key informants, 20 CLCs with the most knowledge of STAR-VA implementation and sustainability at each site, and that included the nurse champion, behavioral coordinator, and nurse leadership. And we conducted 39 interviews with 49 unique respondents, meaning we conducted a few group interviews along the way between December 2018 and June 2019. So in total, you can see here our sample was 43% BC or behavioral coordinators, 36% nurse champions or NC, and 21% nurse leaders. So in terms of initial data analysis regarding the identification of factors affecting implementation, interviews were audio recorded with consent and then professionally transcribed. And then we used the transcribed notes to code a priori knowledge reservoir domains. So we used a consensus process to agree on the coding structure, and then had teams of 2 coders coding interviews, and then used directed content analysis to identify our themes within each domain for each CLC. And then we combined the themes across those 20 sites looking for similarities in factors affecting sustainability of STAR-VA. And then our last step was really to map those knowledge reservoirs to CFIR using a consensus process or team discussion. And then we used the CFIR-ERIC matching tool to identify implementation strategies to potentially overcome the identified barriers. So before turning to barriers, which is the majority of what I'm focusing on, I wanted to highlight that we also learned a lot about facilitators to STAR-VA implementation. And this slide shows the frequency each knowledge reservoir was coded. Actually, I didn't do that because it'd be a little confusing, but I did want to provide the knowledge reservoirs and sort of what we found in terms of facilitators here. So for people, we saw that there were champions, leaders, and direct care workers and whole team involved in STAR-VA implementation. Relationships were a facilitator. There were regular team meetings, one-to-one huddles, in the moment discussions about how to handle certain cases. There were routine meetings about STAR-VA. There were routine trainings and documentation on behavior plans were happening to hopefully improve distress behaviors. And then finally, in terms of culture, there was a commitment to resident-centered care. Overall, there was a relative priority of STAR-VA and support for it. And then within the nursing home setting, there was a collaborative interdisciplinary team culture where many individuals worked together to solve issues. So the focus of the presentation really is on the barriers. So in terms of the distribution of the amount of coding for barriers, we see that relationships, routines, and procedures, and information, space, and tools had the most evidence. And this was followed by people. And then structure, performance, artifacts, and policies, and culture were coded least often. So next, I'd like to describe the barriers in each knowledge reservoir. And on the slide, you'll see some sample quotes as well, which I will show you in a moment. So we found 2 types of barriers within the people knowledge reservoir. So staffing issues, and 19 staff mentioned staffing issues. So they can include staff turnover, staff transitions, and workload, especially with staff with collateral duties leading to staff burnout. 11 sites discussed, actually I'll read the quote so that I don't forget about it. So we've had a lot of staff turnover, so it's really hard to maintain STAR-VA when we have so many people coming and going. Maybe 20% of the staff on the unit now were initially trained in STAR-VA. And then in terms of limited leadership support or buy-in, 11 sites discussed lack of or little leadership support or buy-in, either at the nursing or middle management level or higher. And leadership transitions or turnover also impacted the consistency and support of STAR-VA. And so a quote here was, "We've had a massive amount of turnover in our leadership, which has led to variability in our ability to move forward." So within relationships, there were 3 types of barriers. 7 sites mentioned various setbacks due to staff conflicts or lack of teamwork or lack of positive team interactions among staff. And one quote here was, there is one nurse on the short stay unit that is very active in wanting you to know the STAR VA plan, but she has difficulty getting along with the rest of the staff, so it is hard. 6 sites discuss gaps or needs in communication within or across teams, such as needs for more meetings where other services were included, or communication gaps due to some poor documentation or unclear communication channels. And a quote here is, the nurse champions are supposed to meet with each other. I can't guarantee that it happens every month as it should. And then 5 sites emphasized that silos and reporting structures between nursing and mental health had been detrimental to STAR VA implementation. So an example might be not including a behavioral coordinator to train nursing staff, or generally the lack of ownership of STAR VA. And an example quote here was, people report to different people. So if the behavior coordinator was working with nursing, they report to a different nurse manager and she reports to someone else. It's hard to lead things when you don't own or have the ability to direct things on your own. Within routines and procedures, there were 3 barriers. 5 sites faced challenges with routine documentation of STAR VA, with various templates for behavior or other forms in the electronic medical record. And a quote here was, there are a number of ways they get documented, but none of them are particularly routine. The difficulty there is that it does not necessarily translate into any information ending up in CPRS, which is the electronic medical record. 2 sites identified barriers with trainings, and those were just having to do with one site moving from integral trainings that happen often to more of a new employee orientation for STAR VA. And the other issue with that was around where just training wasn't happening as regularly as it should be for new and existing staff. So in reality, our team has almost no STAR VA at this point. Almost none of the nurses are trained in it. And we have no nurse leaders who are familiar with the techniques. And then lack of routines. There are 4 sites that described a lack of routines and procedures because STAR VA was either seldom discussed in meetings, or only STAR VA event was really at an annual training, and program really had not been sustained at a couple of the sites. So one quote here was, we have not been able to stay in a great routine since we are short-staffed. It has made it hard for nurses to attend the daily huddles. Within culture, there were 2 barriers. So 10 sites had partial or limited staff buy-in with nursing, but also across other local services who only responded to really punctual requests or refused to be involved. Or then there was lack of support from leadership or middle management, where 3 sites kind of described this happening. There might have been resistant nurse managers that wouldn't allow staff time for STAR VA activities, or resistant staff expressing lack of time to implement STAR VA hourly rounding. And then, some quotes were, the nurse champion and I work together and feel invested in STAR VA approach. Outside of that, almost no one else in the CLC really seems to understand what STAR VA is. I've had meetings with the chief nurse, but she is not interested in understanding how the program works or why we need nurse involvement. And then I think the morale has been low here, plus the lack of clarity and leadership and direction in the site at the moment. So in information space and tools, there are 3 barriers. So 8 sites explain that tools at their disposal weren't being used by staff for various reasons. And there's been some confusion around what those notes are supposed to be and when to document. And then 3 sites spoke of facility requirements for uncluttered spaces, hallways, or walls, which really prevented STAR VA posters from being hung on the unit. And this was, as you can see here, that infection control prohibited staff from putting those posters back up. And then 3 sites discussed issues related to usable spaces, including not having adequate space in different ways. So staff not having space for staff to share confidential information, having limited space to sort of store materials because they're cluttered areas, or general lack of space for dementia residents to spend time together. And then there was one consistent barrier identified in structure of performance knowledge reservoir. So 9 sites stated that STAR VA wasn't part of nursing staff performance expectations. And as a result, resistant staff didn't really have the buy-in since it wouldn't have an effect on performance reviews. And further, non-inclusion of STAR VA into these performance expectations made for a lack of protected time in nursing daily schedules to really focus on STAR VA. And then a very quick quote, there are no STAR VA performance expectations for staff. And then there's one consistent barrier for artifacts and policies knowledge reservoirs. 15 sites expressed the lack of formalized rules and expectations. So this was in the form of policies, artifacts, or standards of practice. And this was really a barrier to staff buy-in and stronger implementation efforts. So staff really relied on alternatives ranging from unwritten rules followed by staff, or a required dementia training staff would have to attend as a way to move forward in the absence of formal policies. So a quote was, "I don't think we're a site that references policy enough or sticks to it. Why would anyone adhere to this orientation or model of care if there's nothing in writing that says they should?" So overall, we identified 15 barriers distributed across the knowledge reservoirs. And because we wanted to use the CFIR-ERIC matching tool, we then mapped to 13 CFIR constructs using consensus approach with our team. So we have highlighted which CFIR domains each construct falls under in the parentheses on this slide, following the CFIR construct name. And as you look down the list, you can see many of the barriers mapped to CFIR's inner setting. And you can also see CFIR domains could be repeated, or there might be more than one for a particular barrier. So this step really enabled us to more easily match those barriers that were reported as knowledge reservoirs to ERIC implementation strategies using the CFIR-ERIC matching tool. And then once those barriers were identified, we wanted to next determine which strategies might overcome them. And so I'll show you how we did this. So the output table on this slide, I know you can't read it very well. It really just is an overview to show you what you get on when you hit the query button. And this is that final tab that populates. And you can see that ERIC implementation strategies are listed in the rows in the first column, and strategies are sorted by cumulative effort of endorsement, or cumulative percent indicates the strength of endorsement for that particular strategy across all the listed CFIR barriers. And then tier 1 are in green, and they are strategies with majority endorsements, which meant 50% or greater endorsement from the implementation science experts who participated in the modified Delphi panel. And then tier 2 are in yellow, and those are in the top quartile overall, including 20 to 49.9% endorsement. So for our purposes in this study, we were most interested in strategies reaching level 1 or green here. However, because you can see there aren't a lot of these strategies, we broaden our approach to include those at level 2 as well, or in yellow. So here you can see level 1 and 2 in the cells. And the next 3 slides actually outline which ERIC strategies map to the CFIR constructs in a way you can actually see the results. And so I won't go through how the barriers map to each strategy because of time limitations, but instead we'll sort of give you an overall impression of the findings. You can see there were often more than one strategy per construct, and the percent following that strategy in this slide, each of these 3 slides, is the level of expert consensus. And you can also see that only a few of the strategies really fall into level 1 or over 50% consensus. So then, here is our second table. And you can notice that some of these implementation strategies start to repeat. So for example, identifying and preparing champions, or assessing readiness and identifying barriers and facilitators. So this information is especially useful as stakeholders begin to assess which strategies might be put into place to overcome multiple barriers, and which I've highlighted earlier. So as we get to the last table of barriers, almost all of the strategies listed here on the slide have been previously mentioned in the last 2. And so in total, we identified 39 unique implementation strategies. And of those 39 strategies, there were 7 that came up multiple times. And 3 strategies were really referenced most often, as you can see here: assessing for readiness and identifying barriers and facilitators, identifying and preparing champions, and building a coalition, which is recruiting and cultivating relationships with partners in the implementation effort, in case you were wondering. And then we also see that there were 4 more that were mentioned at least within 2 CFIR constructs, and these were access to new funding, alter incentive allowance structures, conduct local consensus discussions, and involve executive boards. So really the CFIR-ERIC matching tool helped to identify existing strategies that were already being deployed by STAR-VA in the field, which stakeholders thought would be important to continue. So some of these strategies were the importance of the role of site leaders, including the behavioral coordinator and nurse coordinator, and really thinking about identifying which sites are ready for implementation and further work in sustainability. Continuing and enhancing education efforts that included disseminating educational materials and trainings, and then continuing and enhancing engagement of leadership and networks of support, and finally improving the work through small tests of change and larger quality improvement monitoring was important and would continue to be important in STAR-VA. Interestingly, the team also identified opportunities for implementing additional strategies, which would require additional resources from our partner. And some of these strategies are on this slide, and they included I think there were, let's see, I'm just counting 7 that were developed. And there was a readiness assessment checklist to ensure CLC teams and sites had what they needed for success. And then they came up with a dashboard to help identify which CLCs had higher numbers of residents with dementia. Expanded educational materials, including an independent learning checklist. They expanded engagement to leaders in regions. In the VA, that's called VISNs. And then with local quality improvement leadership teams. They promoted community of practices at the regional level, and then expanded local community of practices to include the CLC or nursing home quality improvement teams, and then provided an implementation guide and checklist that helped to identify current and needed strategies, facilitators, and barriers. There was also a tool to identify and track sustainment priorities, goals, and use of resources. And number 7 was a tool to track the quality improvement goals and progress of STAR-VA. So they did actually quite a few new strategies. So then in 2020 and 2021, this year, Dr. Credo led a pilot employing the bundle of 7 STAR-VA strategies at 6 CLCs within 2 regions in the country. And early feedback from these regional consultants and local nursing home teams indicated that the newly developed tools had been helpful. There was some feedback given about when and how to use the tools during implementation and sustainability, indicated some, needed adaptations that should occur. And then these regional consultation groups were really seen as key, and all sites who responded aimed to continue as a VISN community of practice. Leadership support continued to be obtained and seen as important. However, one of the difficulties was that leadership support could still be limited because of turnover and also competing priorities. So in terms of some discussion within the STAR-VA example I provided, we found the CFIR-ERIC matching tool really helped identify targeted strategies to address barriers. And it even helped to reinforce ongoing use of existing strategies that our stakeholders hadn't really thought about or named as implementation strategies in the past. So it sort of gave them a new structure to think about this implementation efforts. And then these new strategies were also developed to address identified barriers and support ongoing sustainment efforts. And we were able to pilot some of these new strategies in the 3 regions for ongoing feedback and adaption. And then we're hopeful that some evaluation of the adaptions will inform some future sustainability efforts as we move forward. So overall, the tool really helped us choose strategies based on CFIR barriers. And this again is complements the work doing implementation mapping processes to further operationalize your approach. I feel like several of the steps are things we did. Now, in terms of future directions for research and implementation strategies more generally outside of STAR-VA, there are 3 main things. I think there are others we could add to the list, but the 3 I wanted to highlight were which implementation strategies are really effective and feasible across various different settings and contexts. How do we tailor strategies in order to be able to assess their effects? And then, what are the mechanisms through which these strategies operate? So I wanted to acknowledge the team involved with the larger evaluation of the STAR-VA program and our funding from Query to do the work. And then if you'd like more information about implementation strategies, there are several wonderful videos available on YouTube. I've included the link to one by Byron Powell for you here on this slide. And I also have my contact information if you want to reach out and chat for any reason about implementation strategies or implementation science more generally. And I think, Ronnie, at this point, we could open up for questions if you'd like to.
That was really wonderful. Dr. Sullivan, thank you so much for sharing so much information about implementation strategies. As people are thinking of questions, I really wanted to just jump in with one. I mean, you've given us such a really nice, thorough description of how you use your formative information to identify the barriers. And you really emphasized the importance of, building on evidence from the CFIR-ERIC matching tool, as well as the way that you need to specify and operationalize, because that's one of the things that often doesn't get done. And so my question is really on that latter part of specifying and operationalizing. I really liked how you gave like the general description of a strategy according to the ERIC paper, promote network weaving, for example, but then you gave a very specific description of how you're using that in STAR-VA. What advice do you have for people when they're trying to do that specification and operationalization? Like, how is that really just from the interviews, or is it from more of other types of investigative work that you need to do? Like, how do you know who's the actor, who's the targeted audience, the frequency with which this has to happen, the strategy, the dosing of the strategy? Is it once a week? Is it once a month? Is it several times? How do you make that leap from naming to specifying and operationalizing?
In our case for STAR-VA, and I was less involved in this process because it really, once we had our findings, it went over to the stakeholder and Office of Mental Health and Suicide Prevention, who were leading the efforts to really discuss the findings around the strategies and then figure out, okay, wow, what do we actually have several of these in place already. That's really great, but then it was like, now what do we do? There's all these barriers. At the time it was interesting because the office had already had some ideas about things they wanted to do, which matched up with the findings, right? So they were, able to kind of link them up with that wonderful table of new strategies developed. It's like, oh, these actually match. We have some of the issues we think we're encountering in the field from our own experience in these community of practices. So that was one way it was really about the stakeholders' feedback. Now, I have to say, even though they're specified that they have a title, we did not go through and do the whole, specification of the actor and the action targets and the temporality and the dose, right? So that was something I think that's probably still could be laid out better. I feel like you need implementation scientists to sort of involved a little bit with that process so that you can better define and look at those things. And, I think some of the more recent work actually lays out each of those things, and you fill in a table to kind of say, okay, let's think about this strategy. What is it? What outcome do we think it will affect? Implementation outcome. So I think that part of it is thinking through critically and answering those questions, but working really with your stakeholders to get that done, or the communities of practice to understand what they want and what's going to happen in the field. So I don't have a really good answer. I would just say it was just a mix of things that kind of came together to get us where we're at. But one challenge of not laying it out in a table that kind of specifies everything is this is a bundle that's being put into place of 7 strategies, and we don't know is it the bundle, which strategy has the biggest effect. Do we need to know that? There's so many questions still to kind of think about in the evaluation of those strategies. Does that help?
Yeah, I mean, I think it's just it's such an important part of the strategies, and yet, especially when the implementation efforts are being done as they should be being done by the people and the front line, the clinics, the providers, that there's also what's ideal and then what's really practical. And so when you specify something, thinking through like what in operationalizing it, what could really be done, especially if this is something that's being done within the clinic and not from an external research person delivering a strategy, I think is really key. And I just want to emphasize that last point, because I think that's what's so important about the work that you've done, is that this is literally the people on the ground doing these strategies, as opposed to a research team member doing that. And I don't know if you have anything more to say about that, but I think it's important for people to realize that, this is really moving towards sustainability if you can get people on the ground to actually deliver the strategies as part of their day-to-day work.
Yeah, I totally agree with that. I don't think I have much to add. I would say, STAR-VA is an initiative that has been going on for some time. It's really built into the organization at the local level, regional level, and national level with support. So it was really embedded really from the start. And I think that's what's led to so much success. Even though I really highlighted barriers, it's been very successful in terms of its program and outcomes, which we also presented. There's been some recent papers regarding the effectiveness of STAR-VA sustainability.
There's some comments in the box just really saying thank you for what a well-structured and well-presented topic. And also that, you're obviously talking about something very complex and you made it very understandable for people.
Oh, good. Thank you. I know it's very complex. It's hard to kind of discuss all these things.
There is one question of a question about that you posed at the end about mechanisms. With the ERIC strategies mapped to CFIR, this implies part of the strategy, the mechanism pathway to the strategy that helps us to understand the effectiveness of an implementation effort. So sort of, if you are trying to understand what makes a strategy work, that mechanism pathway is really important. Could you comment more on the distinction you're identifying here?
Yeah, sure. Let me see if the slides are still showing. Is that correct? Yes, I think so.
Yeah.
So I prepared this additional supplemental material slide because I had a feeling this question would come up. I can't see it very well, so I'm going to look at my other monitor here. But this is kind of an example of a article that has looked at, you're looking at classification of strategies, but what are those mechanisms and what's the causality that happens? So for example, here on the top, you can see that there is a depression screening electronic medical record decision support prompt. And then, what do we see here? That there's habituation to prompts, and the prompt is noticeable. The mechanism is salience and awareness in this case. And then there's moderators, clinic visit length, and PHQ-9 form is available and accessible. And that's the form to measure depression. And then the proximal outcome is clinician administers the PHQ-9, and the distal implementation outcome would be depression screening rate increases. So it's a really interesting paper, and this is an area where I think a lot of work is going to be done, and I believe there's been a recent large grant to look at these mechanisms in more depth and try to understand them. But this article really is a good one to get you thinking about that.
Yes, and that's a nice segue into me promoting a talk on November 30th in our series. Dr. Hannah Frank will be talking about very specifically about educational implementation strategies, and she's part of that mechanism work group that Kara Lewis is leading. So we'll have more time to focus on that mechanism. So Lauren, thank you for that that great question. So Jenny, a lot of the times when people are, listening to us talk about our VA work, the question that comes up is how do you even begin to do any type of effort like this outside of a large integrated healthcare system? And I don't know if you have any sort of comments or thoughts for people who don't work in such a system where there's leadership at the top really trying to get evidence-based practices, into routine care. How would you even start to, like, what advice would you give to someone who's, say, working at a local Providence hospital and trying to do this type of work? What would you suggest?
That's a hard question because I find myself, I've been in the VA for almost 20 years, so it's really hard for me to take my understanding and kind of flip it. But I think, at the team level, if someone's on a team and looking to do quality improvement work, you mean the one nice thing in Rhode Island, I think about Dr. Elway is your group and all the consultation you do. So the importance of trying to find someone you might link up with who understands these concepts is useful, even in a consultation. But really, it's taking the concepts we've talked about and think about, that implementation research methods framework. Okay, well, what are we doing? And so I know what I do when I'm working with groups is really think about what is our intervention, what are our clinical outcomes, and what are you trying to do in the middle? Like what could we move? Like what is most important to you here? And I think that framework does provide teams working on specific quality improvement issues or trying to implement a new clinical practice to think about what they're doing, and some of the guidelines provided in this presentation should help. But I do think being able to do a consult with implementation scientists does really help, even if it's one meeting, to just kind of learn more about the things you should be keeping in mind, because there's a lot of them. Ronnie, do you have other advice? I mean, I feel like there's so many different things a team could be doing.
I think that the idea of starting with a single hospital or maybe a couple clinics, not thinking that you're going to be able to do something really widely, but, always starting at that engagement point, really trying to learn from people, not going in making, trying to assume that you know what the challenges are, but learning from people on the ground. So yes, I think, pieces of everything that you've mentioned can be relevant to work that is single site as opposed to a larger integrated healthcare system. Let me see, there's a comment again saying thank you. And I know that we're almost out of time. Next week we'll have another terrific conversation and presentation by Dr. Sarah Becker at the School of Public Health, who has been the PI of multiple R01s funded by different NIH agencies. And so we will be learning from Dr. Becker on hybrid effectiveness implementation trial designs, which is really where you'll put a lot of this information on implementation strategies to the test. And Dr. Becker has led hybrid 3 designs where you are testing implementation strategies. So we'll definitely look forward to hearing from her. We'll see you next Tuesday, which is November 16th. Thank you so much, 10 a.m. Thanks again, Dr. Sullivan.
Thank you.